Well, thank you very much, everybody. We really appreciate the opportunity to be with you today and to talk a little bit more about the COVID-19 vaccine and some of the perceptions about the vaccine that are found among agricultural, fishing, and forestry audiences. Next slide, please. So the work that we're going to present today is really a cross-center work. So as you heard about, this is part of the Southeastern Coastal Center for Agricultural Safety and Health. But all across the country, there are 11 different ag centers that serve agricultural and rural populations. I'm actually with the Central State Center for Agricultural Safety and Health, which is in the middle part of the United States. We serve a 7-state region consisting of North Dakota, South Dakota, Nebraska, Kansas, Missouri, Iowa, and Minnesota. And you'll also hear from colleagues at the Southeast Center for Agricultural Safety and Health and Injury Prevention, which is based in Kentucky. Next slide, please. And so there's 4 of us who will be speaking with you today. I do want to invite questions. Feel free to leave any questions in the chat. I know Philip will be moderating the chat for us. And that's always a good way to put any thoughts down there, and then we'll come back to the questions at the end of the presentations today. Next slide, please. So the first project that we wanted to talk about is one that I've been involved with. And this is actually a project that grew out of the National Occupational Research Agenda, the NORA, for ag safety and health. And what we did is we developed and are developing a white paper regarding COVID-19 vaccination. And it's bringing together experts from all across the country who have background and experience in working with farm workers in rural populations. The second project that you'll hear about today is the Sondeos project, which is about looking for local knowledge and informing vaccination efforts among the ag, forestry, and fishing workforce. And finally, you'll hear from Dr. Galindo about some findings from a survey that was conducted with extension personnel to identify their attitudes and behaviors that are associated with COVID-19 vaccination. And of course, we'll take any questions. Next slide, please. So what you're seeing here is a map of some of the COVID-19 outbreaks in the agri-food system. We all know that COVID-19 has had a disparate impact on the agricultural system, on the agri-food system. So what you see here is the outbreaks that were associated with farms are presented in blue. The outbreaks associated with meatpacking are presented in red, and the outbreaks presented in orange are associated with food processing. You can see this has had a tremendous impact all across the country. And this data, it comes from the Food and Environmental Reporting Network. And as of August 13th, you can see that there had been 438 farms and production facilities that had confirmed COVID-19 cases. And according to FERN, 13,719 farm workers had tested positive and 107 had died from COVID-19. Now, there is no one national data source about COVID-19 and the farm working population. So oftentimes we're having to rely on media reports or estimates. In fact, Purdue University created a calculator to estimate the number of workers that may have tested positive. And they're estimating about 936,000 agricultural workers nationwide have tested positive. But again, these may be undercounts because they're not including contracted or temporary labor. And so there's a lot of issues with the data that we currently have. And I think this is just another example of some of the issues that we have just in general of trying to quantify the number of workers and the types of things that are going on in this industry. So there's a lot of reasons for that, but we do know for sure that this has had a really tremendous impact on workers in this industry. Now, why might that be? Well, part of the reason is related to the crowded spaces, the essential nature of the work. Oftentimes farm workers, agricultural workers, they're sharing housing and they're also sharing transportation, which increases their risk for actually contracting COVID-19. And not only does this have an effect on worker illnesses and worker deaths, as the data is showing here, but it also has an impact on the production and the supply chain throughout the industry. Next slide, please. So we know it's really critically important to figure out a way to roll out the vaccine to these populations. It's very, very important, but it's very, very challenging, logistically challenging. And we know that this is an urgent challenge that we have to do a lot more thinking about. Because when we started writing this white paper, it was actually back in December of 2020. The vaccine was almost on out to the public at the time we started thinking about this. And then things took off and things moved so fast, it was hard to keep up with the actual writing of the white paper. And I think now we've seen some of the results of the vaccination efforts, although we've done, I think, you know, as well as we could have done in the short time frame that we've had, we now realize that there are a number of holdouts that are more challenging to get vaccine to people for a number of different reasons. Some of those reasons have to do with structural issues and figuring out how do we disseminate vaccine, particularly some of those that require cold refrigeration, sociocultural issues, and dealing with the levels of mistrust and miscommunication, disinformation, misinformation that may be out to the public, and understanding how do we overcome some of those things so that we can build confidence in the vaccine. And finally, of course, logistical concerns and making sure that we're able to deliver information to people in very diverse workplaces and in very rural and remote areas. So these are many of the challenges that we have to face, but we know this is critically important work that we must do. Next slide, please. So an effective vaccine rollout is one that has to account for the context of the agricultural industry. And so when we're talking about the ag industry, we realize that there's a lot of different people that are encompassed in the ag industry, everybody from an independent farmer to perhaps an undocumented or a trafficked worker. And so when we're thinking about strategies around vaccine rollout, we need to think about the formality of the employment agreement and how that may affect people's willingness to become vaccinated, or their trust in the vaccine, their trust in the employer and the information that's being provided to them. We also need to think about the mobility and the temporality of the work that they may be engaged in. How do we track people across different commodities, across different geographic spaces, so that we can make sure that not only are they getting information, maybe getting one shot, but they get the follow-up shots, maybe they get booster shots, whatever it takes to make sure that people are protected from COVID-19. And third, we also need to think about the legal protections for the workforce and how those vary depending on where you are in that spectrum of the workforce and how that may affect your ability to access vaccine, your ability and your willingness and confidence to actually go through with it. And really a lot of the structural concerns that are associated with getting these vaccines out to people. Next slide, please. And so we know that COVID-19 vaccination and the hesitancy is decreasing, but we feel that it's really important that we continue to do outreach, particularly to agricultural workers. And so we've developed a number of overarching recommendations, which you can see here on your slide. First, to make sure that you're tailoring your strategy based on the dominant ag, forestry, and fishing industries in your area, whether that be crops or livestock, and whether your workforce is stable or seasonal. You need to be able to adapt your strategy and understand how that strategy is affected by the production work that has to go on. Second, use trusted sources. So some of those trusted sources may be Farm Bureau and Extension, particularly when you're thinking about independent producers, but you may be also looking to churches, school groups, commodity groups to try to get information out to other workers. So understand who are those trusted sources of information in your area. Who is it that the ag populations are listening to and that they trust? And try to push information out through those sources. And the third overarching recommendation would be to really be attentive to the challenges in accessibility, acceptability, and the availability of vaccine in your local area. So make sure that you're crafting your messaging to provide some of this logistical information. This was particularly important early on when we heard that many ag workers, even though they would accept the vaccine and there was some support, they didn't know how to access it. And so making sure that we're providing all the information that people are going to need to be able to make that decision, make it easy, is really important in the messages that we create. Now, thinking specifically about ag, forestry, and fishing employers, and what are some of the recommendations that we could provide to them? Because we know they're critical partners in making this vaccination campaign productive. So the first one is to partner with the local public health agencies, healthcare organizations, and to provide opportunities to actually do vaccination clinics on site. We know that when we bring the vaccine to workers, there's a lot greater uptake of the vaccine. Instead of trying to get information, tell people where to go, how to get there, and all of that, make it easy for them. And so having a vaccination clinic on site is one of the ways that you can do that. I know early on there was also a lot of concern about asking for immigration status or any type of social security number or other documentation, and we would suggest not doing those sorts of things because those can create additional barriers for people to be able to actually access the vaccine. The second is to make the vaccine available as part of your standard intake process and your training processes, particularly when you're bringing in guest workers on the H-2A or the H-2 visa process. Third, provide paid time off. If you're not bringing the clinics on site, provide paid time off for people to actually go and find the vaccine out in the community. And make sure that you're making some paid time off available for people who may experience some of the negative side effects from the vaccine. Fourth, we would encourage people to use community health workers so that you're providing culturally, linguistically, and literacy appropriate information to people about vaccines. Oftentimes, people from the communities have a greater insight into what are some of those barriers or what are some of those thought processes that may be going on in factoring into people's decision to actually get vaccinated or not. And sometimes as an outsider, it may be hard for us to understand some of those things. So that's why we'd encourage you to partner with some of those people who may have more local knowledge or cultural knowledge of the population that you're trying to reach. And finally, number 5, we can't forget that we still need to provide proper personal protective equipment and sanitation facilities on the farm to be able to reduce COVID-19 transmission. It is not enough to just make a vaccination clinic available, but we must continue with the same precautions that we have been using throughout the pandemic. As you all know, there's been a lot of skyrocketing cases, particularly right now with the Delta variant spreading so fast across the country. And even people who are vaccinated are getting, are contracting COVID-19 right now because the Delta variant is so transmissible. And so it still continues to be very important for us to maintain those same personal protective equipment and sanitation procedures as before. Next slide. So here you can see all of the people who have been working as part of this NORA group, myself, Annette Greer, Marcia Swidesell, Catherine Crawford, Claudia Corwin, and Joe Gerskowitz. So we want to thank you all for the opportunity to share this information with you. And I'd be happy to answer any questions at the end of the presentation. Otherwise, I will pass it on to my colleague, Shannon. Thank you so much.
All right, thank you, Athena. A lot of what Athena shared just now really overlaps with our findings. I will be sharing with you results of some focus groups. They're called sondeos. They were rapid response kind of information gathering out in the field. And so Rhiannon and I will be sharing what we did with kind of a deep dive into perceptions about the vaccine, local knowledge, and then ways that we can inform vaccination efforts around agricultural, fishing, and forestry workers. You can move forward to the next slide. So a little bit about even the purpose of this and how we got involved in this project. The Southeast Coastal Center for Agricultural Health and Safety organized a meeting where groups from all around our region, and our region, we are in Kentucky, the Southeast Center, and our region overlaps quite a bit with the Florida Center. We have Kentucky, Virginia, West Virginia, Tennessee, Georgia, North and South Carolina, Alabama, and Mississippi. And we were interested, as the Southeast Center was working to put together educational materials and outreach materials, just interested in knowing what the situation was, how much access did people in ag communities have to the vaccine, what are their perceptions, and then really what was their preferred method of receiving information. And so we participated in helping identify groups that we could speak to with these sondeos. At the same time, a group of research assistants were looking at policies across states to understand where ag communities were mentioned within vaccination efforts. So that happened across the region. And then we specifically worked on these sondeos. So these sondeos are about 30 to 45 minutes, and groups from multiple evaluators. So we would have 3 to 4 evaluators that would come in, or I guess people who were running the sessions, people who have different disciplines or different perspectives. And we came in with questions, but we came in also with our own perspectives. And so it's in many ways an informal conversation that was driven by a set of questions. In our region, we had 4 listening sessions with established organizations that were working with agricultural, forestry, and fishing groups. And we had a total of 12 summaries. So the way that we would work these is we would conduct the session, and then right after we would each write down our perception of what we had heard, and then we would discuss what we had each heard, and then we move forward with an inductive coding process to identify themes that were coming together from the research. You can move to the next slide. The questions that we asked were, first of all, the attitudes and perceptions about the vaccine. So we were asking what people who worked with, so for the most part, we were working with people who work with ag communities, not necessarily the farmers. But we asked what they had been hearing from the people that they worked with or served or represented about the vaccine. We asked what they knew or had heard about the plans for distributing the vaccine to their groups. We were interested in knowing if there was access to the vaccine. We conducted these groups in the spring. And so Rhiannon will share that for the most part, at that point, access was not an issue, but early on access had been an issue. So we were wanting to know if it was continuing to be an issue for ag communities. And then we wanted to know the needs and opportunities to provide support. So really trying to understand how to shape educational efforts around the vaccine. So the questions we specifically asked were what questions that they and the people they worked with would like to have answered regarding the vaccine, and really a preferred method of receiving the information. Next slide. So I'll pass it over to Rhiannon to share our findings.
Thank you, Dr. Sampson. So since we used this listening guide that had these 3 questions that drove the focus groups, our results were came up to be organized in that way as well. So the first bucket we're looking at is the attitudes and perceptions from these groups. And out of this first question, we got about 6 themes. And one of the first things that folks really wanted to talk about were the fact that everything is highly divided. A lot of the people in these groups actually knew each other before us coming in and asking them these questions, which I think helped somewhat with them being open and honest about their opinions and perceptions. And but it was highly remarked on how divided the opinions and about the vaccines were. The other thing that they really focused on a lot was that there is an aversion to any form of coercion, force, or shaming being used to encourage folks to get the vaccine. Very much this focus on independently deciding to get the vaccine. They really didn't want to see any form of coercion, force, or shame being used to persuade folks. Other things that they remarked upon were the rapidly changing nature of the information and the presence of misinformation out there regarding the vaccines. Really not knowing who to trust, which sources to trust. And one point out of that came up quite a bit was the concern that the vaccine was made too quickly. And they've heard that a lot from some of the folks that they work with. Another point in terms of the quality of information and misinformation is the circulating concerns about risks to fertility, especially for certain age groups. That came up a lot as a reason to perhaps not get the vaccine. And finally, in this section, there was a lot of discussion about the politicization of medical information and how that is affecting people making decisions, and which dovetails a lot with how divided the perceptions are as well. Next slide, please. As for the second question, when we had asked about the vaccination plans, as Dr. Sampson mentioned, at that point, we were a little bit further along in the vaccine rollout here in Kentucky. And so at that point, most folks in the focus groups decided that, or believed that access wasn't so much an issue anymore. However, they did have a lot of opinions and comments about how access or lack of access was present in the early rollout, particularly in rural areas. A lot of folks chose to travel if they could to get to regional distribution centers to get their vaccine if they wanted it. Another issue that people remarked upon was the use of online appointments, and for the earliest forms of the vaccine appointments, especially since the earliest people who were eligible for the vaccine were the elderly. So lots of issues with whether or not elderly folks out in rural areas had internet access, new technology, and were comfortable enough with it to actually get themselves an appointment, or even if they had some impairment issues that would limit their ability to make those appointments. But at this point, at the point that we asked folks for their opinions on the vaccination plans, most people believe that for the most part, the vaccine plans had rolled out to a certain point, and that access in general was no longer an issue. Next slide, please. Oh, I'm sorry, you already went there. So the final question we asked folks was really about what opportunities are there for us to provide support? What things do you think we should have done differently, or the powers that be should have done differently in order to, get some information out there so that people would be willing or be able to get the vaccine if they wanted it? And some of the biggest things that they pointed out to us were identifying those appropriate messengers. And there were some differing opinions on who those messengers should be, but overwhelmingly, the folks should be local. Often the messengers that were identified were family physicians or physicians of some type, or even just well-respected people within the community. The other overwhelming response was, figuring out what that message should be. And there were differing opinions on this as well. However, a lot of folks thought that we should be focusing on, trying to educate folks about the safety of the vaccine, about trying to address issues with concerning, the concerns of the length of time that it took to develop the vaccine, as in it was too fast. However, addressing and educating on, the amount of resources that went into the process, and focusing on, cutting the red tape for for the FDA approval and those types of things. The other issue that kind of popped up for opportunities to provide support was increasing that access to workers for vaccine appointments. While the vaccines were readily available in the communities at this point, a lot of them were available at local health departments or pharmacies. That doesn't mean that everybody could get an appointment, often because of work. So, you know, are there appointments available at different times during the day? You know, if someone is working odd shift hours, is there an appointment available at a workplace that maybe they could go to? Or even, is there parking available for someone, a worker who might need additional concerns with their parking, or if they're using a trailer or have a very large truck, or they're hauling equipment, these sorts of things. Next slide. So that last bucket really kind of feeds into our recommendations and conclusions. So, you know, increasing access for workers to the vaccine. So appointment times and ability to partner with, you know, employers in order to give more access to these appointments, or even facilities that have additional parking facilities, so that folks who are hauling equipment or have large trucks or that sort of thing can park those vehicles and still go in and get their appointments. So time and ongoing easy access so that folks can get their follow-up vaccination appointments as well is also an issue. A lot of folks thought that, you know, just time, give folks time in order to get comfortable with the idea of the vaccines and keep access to the vaccination appointments open and easy. We also recommend the use of local messengers whenever possible. Local family physicians seem to be the favorite in these sondeos. However, not everyone has a local family physician. A lot of rural areas have issues with access to physicians. They don't have enough medical staff in the local community. Not everyone has insurance so that they can go see a local family physician. So while there seems to be a favorite in who might be that local messenger, it doesn't mean everyone has access to them. So other messengers that were suggested included extension agents or other well-respected organizations with which AFF workers work. The messages focusing on educating and showing folks that the vaccines are safe, and directly addressing some of those concerns that we mentioned earlier about the time it took to develop the vaccine and the effort and the resources involved. Some folks also mentioned, you know, pointing to other vaccination success stories, such as polio in the past, especially for some of our older populations. They kind of remarked on that in some of their discussions. And then lastly, multiple times throughout these sessions, the issues on the perceived fertility concerns with the vaccine were brought up repeatedly. And while we tried to press some of our participants to provide us with some more information on, you know, where they're getting information about these concerns, most of them would just say, you know, oh, I've read some articles, or, you know, I heard it from someone, or saw it on social media. But we really think that there should be, we should be looking into more information on where these concerns are coming from, particularly if females of reproductive age are concerned about getting the vaccine. Women in the household are often the connecting piece for getting family into healthcare. So if we have women out there who are concerned about these issues for themselves, they might have concerns about the vaccine for the rest of their families as well. So that could influence them being that connection to healthcare, and in the vaccines and kind of influence whether or not whole families potentially could be or could not be getting the vaccine. And at that, I will pass it back to Dr. Sampson.
Thank you, Rhiannon. One other recommendation, just a comment, is that in some of our groups, the people who were pointed out, or the groups who were pointed out to be likely trustworthy information givers, when we talk to some of those groups, because of the politicization of this of vaccines, some of these groups were very hesitant to talk about vaccines. They didn't want to risk their relationship with, their professional relationship with some of these communities by perhaps taking a stand or making it look like they'd taken a stand on the vaccine. And so that would be another recommendation, is to maybe empower some of these groups that are trusted, like churches and agricultural extension agents, to have good information, trustworthy information to hand out to people who ask, rather than to try to encourage or to try to, they don't want to have to take a stand. They don't have to take a stand, but rather to be the ones who can give out trustworthy information. We did have a few limitations with our work, and one of the main limitations was that we had a lack of diversity in the focus groups, and primarily that lack of diversity was racial diversity. We did have gender diversity as we continued our groups, and we did, during the spring, attempt to engage with workers of color, but we weren't successful within that time frame. So you can give the next slide. So we are continuing our work. We are doing a second round now, and we're specifically reaching out to folks who work with migrant workers and also Black farmers, trying to hear their perceptions of the vaccine, so that we can make sure that we are addressing the concerns or the needs of the marginalized voices. We're also working with public health workers who are serving communities with workers of color. So that's our continuing work. And so I guess stay tuned for additional information. Thanks, Sebastian.
Thanks, Shannon. Hello, everybody. I am going to share now with you some additional results from a survey. You will notice many similarities with what my colleagues have presented in their findings. However, in this case, we were focusing on a very particular audience within agriculture, fishing, and forestry, extension professionals. Just as background information, probably some of you attended a webinar that we presented last year, or maybe our State of the Science meeting, where we reported on the results of an initial survey that we conducted in 2020 between May and June to explore the impacts of COVID-19 pandemic on extension professionals. At that time, we received 485 completed or partially completed survey questionnaires, which represented a 74.7% response rate. In 2021, this year, we deployed a new survey, a follow-up survey, and we have a total of 404 completed or partially completed questionnaires. And we had some of the participants that had completed the first survey also completed the second survey, the follow-up, but we also had some new participants in this second survey. The overall response rate for 2021 was 48.2%, a little lower than the first time, but still a good response rate. And one of the main differences in this second survey is that we included also support staff, which in the first survey we were not including support staff as potential respondents. So looking at the respondent profile, we can notice that about 2/3 of the respondents were either county agents or state specialists, followed by support staff, multi-county agents that here we're including also regional specialized agents and state specialized agents and also regional specialists. And then administrators, and finally a small proportion of people in other roles. And here we have program assistants and educators within FNEP and SNAP program, and also other program coordinators. At the time that we conducted this survey, a large percentage of extension professionals had already received the COVID-19 vaccine. We can see it here, or they had plans to receive the vaccine. If we look at those that had plans to receive the vaccine, most of them wanted to get it as soon as possible. So considering these two categories, those that have already got the vaccine and those that wanted to get it as soon as possible or had plans to get the vaccine, even if they still didn't know or wanted to wait a little more, that is a proportion, that is some numbers that are helping us approach to the needed numbers for herd immunity, at least within these two categories. One inference that we can make is that extension professionals, at least they are leading the way in getting vaccinated and also following the science, what is available, the recommendations, the information that they have available. We had other questions in the survey that looked at the sources of information and everything, and you can go back also to the recording of the webinar from last year, and you will see some of the other things that we asked in the first survey. And we kept some of those questions, but for this presentation, we are not getting into information channels or other aspects that we explored. Now, when we compare the responses, what people responded, we have 257 people that completed both surveys. So we were able to make a comparison to see if they remained consistent or not with their initial response from 2020, and in 2021, that was very similar. So we can see that most of them, for example, looking at the yes, most of those that said yes in 2020 had already received the vaccine or were going to get the vaccine. However, very few of them had now were maybes, and a very small number now were saying no. When we look at the maybes from 2020, more than half of them had already received the vaccine or planned to get the vaccine, but there were still a large number of individuals in this group that were still a maybe, and some have already moved into a no. And in the no category from 2020, we can see that a very small, well, three of those participants, 3 out of 16 participants that said no in the first one had already received the vaccine. 1 wanted to get the vaccine. 3 now had moved into a maybe, but we had 9 that remained in the no. And the question that we asked is, originally in 2020, if a vaccine were available, would you get it? That was the question that they received in 2020. And the question that we gave them in 2021 was, now that the vaccine has been deemed safe and effective by the FDA, would you get it? And that is where these numbers are coming from. Now, when we look at the vaccine intentions by role, we can see some variations here in how the respondents, depending on the role, what were their intentions. Just over half of county faculty reported having already received the vaccine, which is a rate lower than all other roles, with the exception of support staff. A large proportion of state specialists, multi-county faculty, that includes the regional specialized agents, the state specialized agents, and the regional specialists, and also the administrators, they have already received the vaccine. So Vaccine hesitancy, that means those who said maybe or no to getting the vaccine, was highest among support staff, followed by those in other roles and also county faculty. Looking at the COVID-19 vaccine intentions and the associated reasons for getting or not getting it, looking at those who had already received the COVID-19 vaccine, and this was the largest group of respondents, the most common major or minor reasons for getting or not getting the vaccine in this were age, health history, and the opinions of friends and family members. However, being worried about possible side effects of the vaccine was also often mentioned. Continuing to look at this, the reasons associated with getting or not getting the vaccine, and now looking at those that said yes, they intend to get the vaccine, which was the next largest group of respondents. The most common major or minor reasons were very similar to the previous one: age, health history, and the opinions of friends and family members were very important. However, being worried about possible side effects was also mentioned frequently, as was a concern with the role that politics had played in the development process of the vaccine. So as you can see, we are starting to see a lot of connections across the three different studies that we have shared in this along this webinar. Now, looking at the reasons for getting or not getting it, not getting the vaccine, but focusing on the group that said maybe to getting a COVID vaccine, the most common major or minor reasons that they shared were they were worried about possible side effects. Politics has played too much of a role in the development process. Health history and age were also important. Lack of trust in the government and lack of trust in vaccines also played a role here. Finally, looking at those that said no, they are not going to get the vaccine, the reasons that the major and minor reasons were that politics has played too much of a role in the development process of the vaccine. They don't trust the government or don't trust the vaccines in general. Some of them were worried about possible side effects, and also there was this idea that also the risks of COVID-19 have been exaggerated. Another thing that we asked participants was if they had talked with their clients about their clients' plans regarding getting or not getting the vaccine. And just over 1/4 of respondents had actually talked with one or more clients about the COVID-19 vaccine. And we found that respondents across all extension roles had talked with clients. And generally, extension professionals talked with a few clients, but one of the respondents estimated having talked with 500 clients about COVID vaccination. And the reasons that their clients gave for getting or not getting the COVID-19 vaccine, they varied a lot. And because the sample size was too small, we were not able to discern any patterns across the proportion of clients that are likely to get vaccinated. Looking at the reasons shared by agents that they have heard from their clients in terms of intention to getting or not getting the vaccine, the main major and minor reasons were age, health history, the opinions of family and friends, wanting to wait and see how it works for others, possible side effects of the vaccine, lack of trust in the government, and also that politics was too involved in the process. So right now we have only done these descriptive statistics, and we still have a more analysis to do, and we hope to share a more complete report and probably another presentation with all of you soon. And I want to thank all the members of the evaluation team at the Southeastern Coastal Center for Agricultural Health and Safety that participated in the development, testing, deployment, and analysis of the survey data, and in particular to Dr. Glenn Israel for leading the analysis, taking all the heavy weight of doing the analysis and preparing the slides for this presentation. So having said that, we are ready for your questions and answers. For your questions, we will probably have some answers, sorry.
Yeah, so I'll just take a moment to remind everyone that you can put your questions into the chat box, or if you have any comments or just things you want to share that are relevant to the topic, go ahead and put those into the chat box. We'll give everyone a minute to, kind of think about maybe get your thoughts kind of together and put those in, but feel free to type those now. So there are a couple questions that have come in, and we'll go ahead and start with those. So the first question was, did you tape and transcribe your sondeos? So I can, maybe Shannon wants to answer that one.
We did not transcribe or record the sondeo. So it was more of an informal conversation, and Sebastian might be able to speak a little bit more to the methodology of the way that this is structured, that it's really supposed to feel like an informal conversation, and that the way we analyzed and sort of went from listening to analysis was that each of us did a summary. We had a written summary of what we had heard, and then we pulled together and had a conversation about what we had heard, and we moved forward in that way. So it was less of a deep research study and more of a collection of ideas. Sebastian, do you have any comments on that?
Yes, that's the sondeo method does not, it is recommended not to record the conversation. The idea is to have the participant or participants, because there may be more than one at a time, feel comfortable. And then also the group of interviewers is diverse, they come from different backgrounds. So everybody is engaged, even taking notes is recommended not to do. So all the attention should be in the conversation, and then as soon as the conversation ends, every member writes down the notes, and then they share and then go through a process of integration and synthesis, which is what was done. If you are interested in learning more about sondeos, there's a really good EDIS publication that Dr. Israel and I authored, and you can find it online.
Great, I'll go to the next question. Was there a relationship between the county agents who did not get vaccinated and the vaccination rate in their county?
Right now, we don't know. That is an interesting question. Probably we will need other data sources to look at that, but that is something that we definitely may be interesting to look at. But we don't have with the information that we have from the survey, we cannot answer this question.
And there is a question that I'll open up to anyone. In the states you have researched, have the governors considered requiring H-2A workers to get tested or vaccinated? How about making vaccination a mandate?
Well, there is no mandate around COVID vaccines, and definitely in the states where I work, they're very conservative and do not like mandates of anything, and so there will be no mandate. But the H-2A is a federal program, so there could potentially be some movement at a federal level, but I wouldn't expect anything at a state level.
So we'll go to the next question. Were there particular disciplines of the agents who did not get vaccinated?
We have the data. We have the data. We haven't explored this yet. We collected in the first survey, we collected the specific initiative and program that each respondent was part of. I don't remember. We went through a very intensive process of reducing the original survey, keeping only the key questions, and then adding other questions that were related in particular to perceptions and attitudes regarding vaccination. And also we included other items that we consider important. So I don't know if we have that question in this. I don't remember right now if we have that question in the second survey, but at least for those that completed the first and the second survey, we may be able to go back and look into that. That is also an interesting question, Katie. And I think there was another question there before that one, Philip, about the disciplines represented by the evaluators in the sondeos.
Yeah. So y'all can go ahead and take that one. What were the disciplines represented by the evaluators? Yeah, if you want to go ahead.
We had someone who does evaluation, but comes from an educational background, actually educational policy background. We had someone who was also from education, but spans into an agricultural background. And then the other evaluator was from the medical anthropology background. And that was for ours. I know that the Florida group also did some sondeos. So the hope was that for each of these, that there would just be different perspectives in the room.
Great. There's one more question up here. Can any of you advocate for a federal mandate to test H-2A workers before they get on the bus to come to the US, since it is required for airline flights?
Well, I think that's a great point, Gail. I think any of us could advocate for a lot of these things, but how likely are they to happen? I'm not sure. You know, I've been asking questions to our Department of Labor, who oversees the housing inspections and the certifications on the H-2A employment applications. But from my interactions with them, it seems like there is not a lot that they can do, and it would take more of a federal mandate for that to happen. I think for a federal mandate to happen, that will take all of us working together to try to get something like that to come to fruition. But we are seeing, you know, more movement on a federal side to mandate vaccination for federal employees. So I think there's possibility, but it would definitely take quite a bit of advocacy to see that happen.
And if I may add to that, getting into as the centers that we represent and the universities that we represent, getting into advocacy is tricky. So the best thing that we can do is what we are doing, collecting data in a systematic and rigorous way and disseminating it to different audiences, making it available to policymakers and to others that can use that advocate or to promote policy changes. Really, I think we are walking on a very gray area there as in our positions in the center and the universities.
Yeah,
Yeah,
we
I
really
think the
took that
other-
approach to. Go
Go
ahead.
ahead, Shannon.
Just that within our focus groups, or the sondeos, we made it very clear that we were not there to advocate or to encourage, but really to collect information. And so that really is the stand. And then to provide educational materials that were well targeted, but not, our position was not of advocacy.
Yeah, the other thing that we have been doing is working with the Department of Labor and with farm worker advocacy organizations that when H2A workers arrive in our communities, that we're bringing COVID-19 vaccination clinics on site to the farms or to the housing units where people are staying. So we're trying to make the vaccination available to people when they do arrive in our communities. But I think my colleagues have made some interesting points about the role of advocacy and what we can do as researchers.
And Glenn Israel shared the comment that we do have the data, Katie. So we will be able to look at the vaccination by program area.